Let's talk about traumatic brain injuries. So, traumatic brain injury is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. So, something has to happen from the outside that causes the damage to the brain for it to be qualified as a TBI. Effects of TBI include impairments in cognitive abilities, movement and sensory deficits, and disruption in behavioral responses and emotions. These impairments may be temporary or permanent and not only affect the individual but the family as well. Behavioral changes and behavioral issues are one of the biggest problems that patients following a TBI deal with, and that affects not only the patient but everybody in their support system. TBI may result in lifetime impairments of an individual's physical, cognitive, and psychosocial functioning. The most common cause of TBI is falls. Men are more frequently affected than women at a ratio of 2 to 1, and we can see that there are both, or not both, but all physical, behavioral, and cognitive effects, and you can read through those examples of the effects of TBI. The incidence of TBI peaks at 3 different age ranges. So there's 3 periods of life where you're at greatest risk of experiencing a TBI. The first one is going to be in 1 to 2 years, and that's typically as a result of child abuse and shaken baby syndrome, falls, motor vehicle accidents, bicycle accidents, and the primary risk of injury to children can be reduced by 88% if children wear helmets. 15 to 24 years, and that's going to be more in the male population, and that's going to be that risk-taking age range while the prefrontal cortex is developing, and so we have the physical ability to complete things, but not the planning skills to actively think about whether or not we should be participating in them. And then patients over 75 years as a result of falls being the most common cause of TBI in that patient population. Outcomes are affected by the amount of immediate damage from the impact or insult. Low initial scores on the Glasgow-Coma scale, which we'll talk about in a little bit, especially if those are related to eye opening or motor response, will demonstrate lower outcomes. Cumulative effects of secondary brain damage. The individual's premorbid cognitive characteristics such as intellect, level of education, and memory. The presence or absence of substance abuse. And the individual's pre-injury personality, including their work history and interpersonal relationships. So when we talk about brain injuries, we have 2 different types of classifications that we can look at. We have either open or closed. And so our open classifications result from penetrating types of wounds such as a gunshot, knife, or sharp object. And so this is where something penetrates the skull and the dura to reach the brain. The skull can be fractured or displaced, and the meninges are compromised because the dura is displaced. The risk for infection is higher in these patients because of the bony fragments, the hair, skin penetrating, and the brain tissue that's been penetrated, again, by this external object. The damage to the brain appears to follow the path of the object's entry and exit. So these brain injuries are typically more focal. The deficits present very specific based on the specific path of whatever object has traveled through the brain tissue. Our closed or intracranial injuries come as a result of impact to the head, but the skull does not fracture or displace. The brain tissue is damaged and the dura remain intact. Beyond classifying our brain injuries by how they occur, we can also classify them based on how they present. And so we've got a couple different subtypes that we'll talk about here. The first one being concussion, which is defined as a trauma that induces an alteration in mental status, physical and cognitive abilities that may or may not involve a loss of consciousness. And that's going to depend on the grade of concussion that the patient has experienced. Symptoms may include dizziness, disorientation, blurred vision, difficulty concentrating, alterations in sleep patterns, nausea, headaches, and loss of balance. So a grade 1 concussion, they're going to be confused and dazed and experience difficulty in following directions and thinking clearly, but they remain conscious and symptoms last less than 15 minutes. For a grade 2, they still do not lose consciousness, but they develop amnesia and the symptoms last longer than 15 minutes. For grade 3, we see an unconscious period, so they're unconscious and demonstrate an observable change in the individual's physical, cognitive, or behavioral function. Physical and cognitive rest are indicated following concussion, and then a gradual return to activity. The duration of the post-traumatic amnesia is considered a clinical indicator of the severity of the injury. So how much they fail to remember can help us understand how severe the brain injury was. A contusion would be another subtype, and that's going to be where we have small blood vessels on the surface of the brain hemorrhaging, resulting in bruising on the brain at the time of impact. And we can have either a coup contusion or a counter coup contusion. And we'll see that a lot with concussions, where we have a concussion and a contusion. And these coup contusions are going to happen on the same side of the impact, and the counter coup is going to happen on the opposite side of the impact, and that's a result of the brain moving in the cerebrospinal fluid in the skull and impacting the skull on the opposite side of the impact. So understanding the difference between coup lesions and counter coup lesions is important. High velocity and rotational injuries can cause diffuse axonal injury because the brain tissue accelerates and decelerates within the skull, and we'll talk about that more here in a little bit. Hematomas are vascular hemorrhages with hematoma formation, and we have those named based on where they form. So epidural hematomas form above the dura, and it forms between the dura mater and the skull. It's frequently seen after a blow to the side of the head or severe trauma from a motor vehicle accident. The individual has a period of unconsciousness and then becomes alert and lucid, followed by a rapid deterioration of the person's condition, and these are often life-threatening. Subdural hematomas, a little less life-threatening, but still something that we need to get resolved. And this is where it forms below the dura, so it forms between the dura and the arachnoid mater. It's often seen in older adults after a fall or a blow to the head, and symptoms fluctuate and can resemble those seen in individuals with a cerebrovascular accident. They can experience decreased consciousness, ipsilateral pupil dilation, and contralateral hemiparesis. Diffuse axonal injury is something that's common with whiplash injuries, where a person's head goes one direction and then quickly whips in the opposite direction. And so if you can think of your brain floating around in cerebrospinal fluid, it's got some movement to it in your skull. But that movement is limited by the neuron axons, and when they are sheared because of excessive movement or rotation, we have diffuse axonal injury. So high velocity and rotational injuries can cause diffuse axonal injury as the brain tissue accelerates and decelerates within the skull. Subcortical axons can shear and become disrupted by the myelin sheath. Diffuse axonal injury can disconnect the brainstem activating centers from the cerebral hemispheres. DAIs produce multiple brain tissue microtears as a result of the shearing movement of the brain against the rigid structures of the skull, causing widespread diffuse damage. It's not going to play, so go ahead and play this video on your own if you would like to know a little bit more about DAI. Additional categories of brain injury can include locked-in syndrome, which we've talked about before, is a rare neurologic disorder that can result after TBI. It's just characterized by a complete paralysis of all voluntary muscles except for eye movement. The patient is conscious and cognitive but unable to move, and so it's often deemed that they are non-responsive. They have a poor prognosis. Acquired brain injuries are not hereditary, congenital, degenerative, or induced by trauma at birth. Causes include airway obstruction, near drowning, myocardial infarction, cerebrovascular accident, exposure to toxins, electrical shock, or lightning strike. And sudden impact syndrome is a recurrent traumatic brain injury. Individual receives a second injury before symptoms of the first injury have resolved. They're more likely to see edema and diffuse damage, and typically involves young athletes who return to sports prematurely. Secondary problems occurring as a result of traumatic brain injury. Damage can occur within an hour of injury or as much as several months later, and so we need to be mindful of these problems not only as soon as the injury happens, but as we are working on treating patients moving forward. So they can be at a risk of increased intracranial pressure. We want to know that any intracranial pressure greater than 20 millimeters of mercury is dangerous, and so these patients may have special precautions as far as when they are in bed, they can't lay flat because that increases intracranial pressure. They probably have to lay with the head of bed elevated 30 degrees or whatever level is indicated in the patient's chart. We can also see anoxic injuries, which are a result of airway obstruction, near drowning, or most frequently myocardial infarction, where the brain isn't getting enough oxygen. And we can also see seizures as a result of traumatic brain injury. Diving a little bit more into intracranial pressure, increased intracranial pressure is common after a traumatic brain injury because of the edema. Approximately 70% of patients with serious injuries have increased ICP. Increased pressure causes compression of the brain tissue, decreased perfusion, and possible herniation of the brain through the foramen magnum of the skull. Normal ICP is approximately 5 to 10 millimeters of mercury. Pressure greater than 20 millimeters of mercury are considered abnormal and can result in neurologic/cardiovascular changes. They will normally develop it within the first week after an injury, but know that that's something that they can be susceptible of in the recovery process. And so if we notice abnormal changes in behavior that are related to a patient's position, we may need to communicate that information to the medical team to have their ICP assessed. Contraindications when a patient has elevated ICP include cervical flexion, because that will serve to increase intracranial pressure, percussion, vibration, and coughing. All of those work to increase intracranial pressure, and so those are contraindicated in a patient following TBI, especially when we are monitoring their ICP. Signs and symptoms of elevated ICP include decreased responsiveness, impaired consciousness, severe headache, vomiting, irritability, papilledema, and changes in vital signs. Our anoxic injuries are most frequently caused by cardiac arrest, and they typically cause diffuse damage within the brain tissue because they're not hitting a very specific area of the brain. Some areas are more vulnerable to local damage, such as neurons in the hippocampus for memory and the cerebellum and basal ganglia for coordination and balance. And our seizures. Seizures are discrete clinical events reflecting temporary physiologic brain dysfunction characterized by excessive hypersynchronous cortical neuron discharge. 25% of patients with contusions and 50% with penetrating open injuries develop seizures. Seizures can be triggered by stress, poor nutrition, electrolyte imbalance, missed meds or drug use, flickering lights, infection, lack of sleep, anger, worry, and fear. Contraindications in patients with seizure disorders include vestibular stim techniques, including fast spinning, irregular movements with sudden acceleration and deceleration. If we are working with a patient and they begin to have a seizure, there are a couple things that we need to be able to do to manage that and be able to document appropriately. So if a patient starts having a seizure, we want to transfer them to the floor as quickly as possible to avoid possible injury. Mat table may be appropriate if we're already seated on a mat table, but the risk of being on an elevated surface is depending on the severity of the seizure, the patient could fall to the floor still. We're going to observe the physical signs to see if we've got jerking or if there is static movement through the duration of the seizure. We're going to observe the patient's respiratory status, not only so that we can document it, but so that we can ensure they are in a proper position, that they can breathe and that their airway isn't obstructed. We want to note the duration of the seizure. Patients who remain unconscious after the seizure should be positioned on their side to prevent possible aspiration. So remember that recovery position. We want to get them into side lying, and we'll contact the doctor and the supervising PT. Patients may be on medications for seizure control, which can include Dilantin, luminol, Tegretol, and these side effects are sedative, memory issues, cognition. They can cause ataxia, dysarthria, double vision, and hepatotoxicity. And so being mindful of the effects of medication can also explain our patient presentations. There are some important factors of exam and evaluation that we need to familiarize ourselves in patients with TBIs so that we know how to understand their level of severity. And one of those things is going to be the Glasgow-Coma scale, which is used to assess the individual's level of arousal and function of the cerebral cortex. So Glasgow-Coma is looking at the higher level functions, not basic life-saving functions of the brainstem, but GCS looks at cerebral cortex function. It specifically evaluates pupillary response, so how do the pupils react to light, motor activity, and the patient's ability to verbalize. The scores range from 3 to 15, with higher scores indicating less severe brain damage and a better chance of survival. When we are looking at GCS scores, patients receiving an initial score of 3 to 4 often do not survive. This indicates a high level of damage to the cerebral cortex and is not indicative of a strong recovery potential. Scores of 8 or less indicate that the patient is in a coma and has sustained a severe brain injury. The depth and duration of unconsciousness is indexed by the GCS as the single most powerful predictor of outcome from a TBI. And you can look at scoring of the GCS on table 12.1 in your textbook. So when we're classifying those scores, a mild brain injury would be associated with a GCS of 13 and above and has a normal CT scan with a loss of consciousness less than 20 minutes. Patient is awake on arrival. They may be dazed and confused with complaints of a headache and fatigue. A moderate brain injury is going to have a GCS of 9 to 12. Upon arrival, they're confused and unable to answer questions appropriately. They may have permanent physical, cognitive, and behavioral deficits. And then a severe brain injury is going to have a GCS of 3 to 8. This patient is in a coma, will most likely have permanent functional and cognitive impairments. The most common clinical manifestations of TBI include decreased level of consciousness, cognitive impairments, motor or movement disorders, sensory problems, communication deficits, behavioral changes, and associated problems. And remember, we talked about those behavioral changes can be one of the most limiting for patients following TBI. But we can see here there are a lot of things that we as therapists treat, but it also requires an interdisciplinary approach for TBI. In working with this patient population, we need to be able to document things like their level of consciousness and their cognition. And so being able to understand the appropriate terms that we're using and when to reference them is important. So let's take a look at some of those terms here. Arousal is the primitive state of being awake or alert. So can somebody be aroused? Are they able to be alerted to their environments? Awareness is conscious of internal and external environmental stimuli. So there's a difference between arousal and awareness. Arousal is they can respond, but are they consciously aware of what they are responding to? Consciousness is the state of being alert, aware, oriented, and remembering. So consciousness is putting a lot of different pieces together there. Coma is a state of unconsciousness in which the patient is neither aroused nor responsive to internal or external environments. There's a decreased level of awareness. Their eyes remain closed. They're unable to initiate voluntary activity. The sleep-wake cycles cannot be distinguished on electroencephalogram. And by definition, it does not last longer than 3 to 4 weeks as the sleep-wake cycles return and there's restoration of brainstem function. So beyond a 3 to 4 week, we start to talk about a persistent vegetative state. And so if we're looking at vegetative states, that's when an individual has return of brainstem reflexes and sleep-wake cycles, but remains unconscious. They may experience periods of arousal and demonstrate eye-opening without tracking. They have a general response to pain, such as increased heart rate or respiration rate, sweating, and abnormal posturing. And the individual remains unaware of the external environments or their internal needs, like hunger or needing to pee. Persistent vegetative state an individual in a vegetative state for 30 days or longer is then deemed to be in a persistent vegetative state. Adults have a 50% chance of regaining consciousness once they've met the threshold for a persistent vegetative state. Minimally conscious state is a condition of impaired arousal and characterized by a vague awareness of oneself and environment. They may be able to fix on an object, localized to noxious stimuli or sounds, but that is a little bit different than a persistent vegetative state. Some other definitions that we want to review here. So stupor is going to be the condition of generalized unresponsiveness in which the patient is able to be aroused only after significant sensory stimulation. So this is a patient who's just out of it, but if you do enough sternal rubbing, they're going to kind of at least shake their head around a little bit and groan at you. Obtundity, they demonstrate disinterest in the environment and are slow to respond to sensory stimulation. They sleep a great deal of time. Delirium is categorized by disorientation, fear, misconception of sensory stimuli, and they can be agitated, loud, and socially inappropriate. Clouding of consciousness is a state in which the person is confused, distracted, and has poor memory. Progress through the stages is variable, and the patients may plateau at any stage. So if we look at this as a continuum, patients are typically going to start at the stupor level, progressing to the clouding of consciousness until they can achieve consciousness. However, following a traumatic brain injury, they may not progress through all of these stages. Patients following traumatic brain injury have experienced damage to the brain, so we expect some kind of cognitive impairments, right? Cognitive dysfunction can include loss of memory, poor attention span, loss of executive functions such as poor planning and organizational skills, recognizing errors, problem solving, and abstract thinking, and the inability to control emotional responses, also known as emotional lability. The severity of cognitive deficits is greatly impacted by the ability to learn new skills, and so remember, a patient's premorbid level can affect that after their injury as well. Patients may confabulate, which is either confusing the truth or combining areas of experience that then creates kind of a mixed message, and don't have a clear perception of the reality that they have experienced. Cognitive deficits can impair a person more than physical impairments when their safety is impaired. Motor deficits that we can expect to see: when a patient is unconscious, mobility is impaired, and they are unable to initiate active movement. They may have abnormal postures that we are going to have to not only position them to fight against, but also be proactive in passive range of motion and stretching to prevent contracture development. The two most prevalent abnormal postures exhibited are decerebrate and decorticate rigidity. Decerebrate rigidity has the lower extremities in extension. The hips are adducted and internally rotated with the knees extended, ankles plantar flexed, feet supinated. The upper extremities are internally rotated and extended shoulders, elbow extension, pronated forearms, their wrist fingers are flexed, and the thumbs may be entrapped in the palms. So decerebrate, we have a lot more ease, and so I associate that with the extension, and so you see more extension in decerebrate rigidity than decorticate. Decorticate is going to have more of a flex posture, and both of these postures result from severing of the neuroaxis in the midbrain region. The vestibular nuclei provide a source for that extensor tone. Decorticate rigidity has upper extremity flexion with shoulder adduction, internal rotation, elbow flexion, forearm pronation, wrist flexion, and lower extremity extension. This results from dysfunction above the level of the red nucleus, specifically between the basal nuclei and the thalamus. And patients with significant injury can be dominated by either abnormal pattern. Voluntary active movement is not possible if the patient is unable to deviate from either posture. And this is just a picture of both of those postures so that you can kind of visualize what we're talking about here. No, I didn't forget about you. I was just giving you time to look at it. Continuing on with motor deficits, we may have weakness and difficulty initiating movement, including disorders of muscle tone, whether they are hypertonic or hypotonic. That's going to depend on upper motor neuron versus lower motor neuron injuries. We're going to typically see more hyperreflexia with increased spasticity and rigidity in patients following TBI because of upper motor neuron involvement, but secondary problems can result in lower motor neuron involvement. The reemergence of primitive and tonic reflexes without voluntary motor control can affect the ability to move in and out of different positions, and following a brain injury, that those primitive reflexes can reemerge. Our TLR, ATNR, and STNR, positive support reflex and flexor withdrawal reflex, can all inhibit the ability to initiate movement, and so I would review those reflexes from your PEDS chapter if you are unfamiliar with them right now. Ataxia, motor sequencing, incoordination, and decreased static and dynamic balance may also interfere with performing functional movements. Beyond motor deficits, we can also expect to see sensory deficits. The sense of smell may be lost or impaired secondary to the damage of the cribriform plate or the anterior fossa fracture if somebody has a traumatic brain injury as a result of face trauma. Perceptions of cutaneous sensations, like our tactile and kinesthetic sensations, can be absent or impaired, and depending on the area of damage, a patient may experience visual, perceptual, and proprioceptive deficits. It just depends on what type of brain injury and where the injury has occurred. Communication deficits that we can see can be lost or severely impaired, and so we may need to implement things like communication boards with these patients and using simple phrases and simple commands to help build a communication bridge that we can more effectively communicate with these patients. Patients with severe motor deficits may not be able to initiate communication due to abnormal tone or posturing, and so it's not necessarily a cognitive inability to articulate speech, but more related to a motor dysfunction. Mechanisms other than verbal communication will be explored, so like we talked about the communication boards, we can try to use demonstration, body language type things. We need to be mindful of our nonverbal communication with these patients as well. And eye blinks, head nods, and finger movements are also examples of nonverbal communication methods that we can use. Behavioral deficits are going to be the most enduring and socially disabling. We can see changes in personality and temperaments. We can have patients exhibit things such as neuroses, psychoses, sexual disinhibition, apathy, irritability, lability, aggression, and low frustration tolerance. We want to promote challenges for rehab, or this can promote challenges for rehab professionals, because we have to figure out how to work within those behavioral deficits and still get our patients to respond to the therapeutic needs that we are trying to reach. This can also be difficult for the caregivers and family, because outside of our therapy session with them, they're the ones that have to spend the most time with this patient. And so we need to help educate families and caregivers on appropriate training methods, appropriate communication methods, and all of the things that contribute to the behavioral deficits that present. Associated problems: approximately 40% of individuals with TBI will have other injuries. We have to remember that trauma is a big cause of traumatic brain injuries, and so trauma isn't going to be isolated to just the brain. We can expect to see many other orthopedic conditions involved in traumatic brain injuries typically as well. Serious medical complications as well as orthopedic injuries, and they may present with lacerations, fractures, and even spinal cord injury. Everybody has the God-given right to have more than one thing wrong with them at a time, and unfortunately, if there's a severe enough trauma, that can include having a traumatic brain injury and a spinal cord injury. Acute care interventions are going to be the earliest implemented in this patient population, and our early goals are going to include increasing the patient's level of arousal, trying to get them to have more arousal, working into awareness, working into consciousness to participate in our therapeutic activities. We want to prevent the development of secondary impairments, and this can include things like needing pressure relief interventions to prevent bed sores. We need passive range of motion and stretching to prevent contracture formation. We want to improve the patient function to the level that the patient can respond, and so the patient presentation following their brain injury is going to impact how much function we can have them initially participate in. We want to provide the patient and family with education regarding the injury, not only what areas of the brain have been injured, what responsibilities those areas of the brain have, but also talking about neuroplasticity and what kind of realistic improvements we can expect. And that may not be an easy predictor early on, but it is important to manage expectations early on, and so education becomes really important. The average length of stay in acute care following a TBI may be less than 2 weeks. So we talked about patient contractures and patient positioning, and so one of the most important early treatment interventions is going to be patient positioning due to the abnormal tone and postures. Side-lying and semi-prone position are preferred over supine because of the influence of the tonic labyrinthine reflex being reduced. So remember, our tonic labyrinthine reflex is when we're in supine, where body is encouraged to have a more flexed posture with the arms being flexed, the lower extremities being flexed, and the trunk being flexed, and that's one of our primitive reflexes. In prone, we end up with more extensor tone because of the influence of the reflex. And so side-lying and semi-prone help to reduce the influence of that reflex. Take care in positioning patients due to their respiratory complications, need for mechanical ventilation or tracheostomies. Remember that they can have associated problems, and we need to ensure that we have positioning that takes into consideration all of their problems. We want to position them out of decerebrate and decorticate postures, trying to break up that tone, and a lot of times being able to do something that's going to flex the hips and knees will help to break up that tone. And then we have to make upper extremity positions dependent upon which of those postures they are presenting with. We want to avoid soft pillows and objects, as the patients will push against them and elicit a stretch reflex and exacerbate abnormal posturing. So we were going to use harder bolsters to help support these patients in their appropriate positioning. We know in this patient population we can expect abnormal muscle tone to be present, and contractures develop quickly, especially at the elbow and ankle. And so proper positioning with range of motion and static splinting can alleviate potential complications. Speaking of complications, heterotropic ossification, or myositis ossificans, is one of those complications that we can see in patients following a TBI, and that's abnormal bone formation in the soft tissues and muscles surrounding the joints that occurs after traumatic brain injury, but it can also occur after spinal cord injury. And basically, you get bone formation in the muscle and the ligaments instead of in the bone where it's supposed to be, and that hardening of the soft tissue then decreases its extensibility and its elasticity and all of the great components of soft tissue that allow us to be able to move. The incidence in TBI is 11 to 76%, so it's pretty random whether or not it's something that somebody following a TBI gets, but it is correlated with the increased tone and not receiving appropriate posturing, stretching, and splinting as needed. It clinically presents with a loss of range of motion, pain with movement, localized swelling, and arrhythmia, and its definitive diagnosis is made by CT scan, with common joints being affected being the hips, knees, shoulders, and elbows. Again, we want to utilize reflex inhibiting postures. So remember that semi-prone and side-lying position are going to be two of our better positions to help achieve that. But we want to use postures that are used to inhibit abnormal tone, so break up their abnormal tone. And then once we get it to a point where it's more manageable, it might not be normal, but it's at least more manageable, then we want to facilitate normal movement patterns and try to restore function. When looking at patient awareness and promoting patient awareness, we can do that by orienting the patient to their name, facility, why they're receiving medical care, explaining treatment, communicating in respectful and personal manner, and this should be consistent across the team. So making sure that regardless of whether or not you think your patient can respond to you, whether or not they have any kind of aroused state, you still want to communicate what you are doing with them throughout the entirety of your treatment session and why they're there, why you're there, who you are, where they are, who they are, all of those things to help orient them and increase awareness. Clinicians should never assume that a patient can't hear or understand what they're saying. In the acute care setting, we can also utilize sensory stimulation, and that can include auditory, tactile, kinesthetic, vestibular, and oral stimuli, and that's for assessment or intervention purposes. We do want to be careful with sensory stimulation to limit the time of exposure because overstimulation can cause agitation and fatigue. We want to monitor when the patient is most aroused, so what activities cause them to be the most aroused, alert, and subsequently conscious, versus those that don't really affect them, and that can help us guide our future treatment planning. The patient responses included or should include changes in heart rate, blood pressure, respiration rate, diaphoresis, increased or decreased muscle tone, head turning, eye movements, grimacing, or vocalization. So we want to be on the lookout for any of those things to be able to document them and their how or what activity they had this response with. Use tactile stim with different textures. Noxious stimuli should only be used if there is no response to all other stimulation, and noxious stim includes pressure on the nail bed or sticking with a pin or pinching. Patients following a TBI are often going to be qualified with a Rancho-Los Amigos scale score, and the Rancho-Los Amigos scale is used to kind of qualify their cognitive function and describe what that patient is going to present as. And ideally, a patient progresses through Rancho's scores to restore normal function. So the Rancho's Los Amigos scale of cognitive functioning is a tool used to measure and describe the patient's level of cognitive function. On table 12.2, page 433, I would definitely take a look at that. When we look at the difference between generalized and localized responses are inconsistent and non-purposeful, such as physiologic changes like fluctuating respiration rates, sweating, skin color changes, or goosebumps. They may present as gross body movements, such as increased tone or abnormal posturing, withdrawal from a stimulus, or respond in a similar manner no matter what the stimulus is. Localized responses, however, are going to be reactions that are more specific to the stimulus that's been applied. Patients with localized responses may be able to follow one-step commands, but the responses can be delayed and inconsistent. So this is just kind of an overview of that chart from your textbook. Your textbook goes a little bit more in depth, but understanding that a level 1 is going to be lower level of function, level 10 is going to be restoring to almost normal function. But we have different behavior responses that we can see throughout here. And so understanding what the person's behavior we can expect can also influence the treatment plan. We want to be careful. Our 4s and 5s are going to be confused and agitated and often inappropriate. And especially as they progress from 4 to 5, they kind of have this area where they go from more agitated to more inappropriate, and it just is a kind of a weird line to walk. As they progress to level 6, they become more appropriate, and so they're able to respond better, but you have to do a lot of treatment management and behavior direction and those types of things when you're working with a patient who's at a level 4 and 5. Acute care interventions are also going to include patient and family education. This can be devastating to families, friends, and patients, and most families are overwhelmed initially and may not know how to act around the patient. It is our job to help reduce those fears and teach them how to act around the patient and how to help the patient and all the things that need to be done. We want to educate regarding changes in appearance, cognitive, and physical functioning so that they can be the best advocate for the patient. And as soon as possible, the family should be encouraged to participate in the patient's care so that they get the skill and practice that they need, but also it encourages the patient to participate more when there aren't healthcare professionals around to promote that function. The typical treatment continuum is going to have a patient progressing from acute care to an inpatient rehab. And the primary problems at this stage include decreased range of motion and potential contractures, increased muscle tone and abnormal posturing, decreased awareness and responsiveness to the environment, presence of primitive tonic reflexes, decreased functional mobility and tolerance to upright posture, decreased endurance, decreased sensory awareness, impaired or absent communication system, and a decreased knowledge of the present condition. I would argue that this point needed to be made for acute care as well, but by the inpatient rehab time, we may not have as much direct medical management, and so it can be often the therapist's job to promote the positioning a little bit more effectively, and especially providing that caregiver and family education. So positioning should be changed every 2 hours to prevent skin breakdown or the development of pneumonia. Side lying and prone are the most desirable positions. We want to acclimate the patient to sitting in a wheelchair because this orients the patient and assists with endurance and bronchial hygiene. We can utilize things such as tilt and space wheelchairs for those who lack the head and trunk control, but we can start working on getting them to be able to tolerate upright and initiate some of that head and trunk control by changing the level of tilt that they need to be in their wheelchair. If fair trunk and head control, a standard wheelchair would be sufficient. And we want to correct the alignment the best we can to get the person in the most functional position for upright for needed progressed tasks. If we don't anticipate that our patient is going to achieve an independent ambulatory status for community ambulation, then we probably need to teach them some wheelchair propulsion or wheelchair negotiation skills, with the goal of them being as independent as possible. Remember, behavior deficits can make wheelchair management a little bit more challenging, and so this can be something that needs to be practiced over and over again, not for skill set, but for safety. Range of motion is important to minimize contractures. Greater therapeutic benefits can be achieved through the use of functional positions or developmental postures and positions to increase patient flexibility. Static stretching should be the last choice if possible. So by the time they get to inpatient rehab, we need to have them involved in their stretching and using weight-bearing positions as much as possible to facilitate the stretching. So we want to get them through that prone sequence where we're prone, prone on elbows, prone propping, quadruped, tall kneeling, half kneeling, standing. All of those positions are going to put our joints in a little bit different position to be able to stretch muscles, and we can transition through all of them to effectively stretch the muscles. More effective static stretch is serial casting or static splinting. So if we have to utilize static stretching, then we may want to talk to supervising PT and or medical team about the use of static casting or static splinting so that we can progressively change the range of motion. This is commonly more done in the pediatric population, but it can be seen in TBI population for knee, ankle, elbow, and wrist. When performing range of motion, it is necessary to be as efficient as possible. Greater therapeutic benefits can often be achieved through the use of different developmental postures and positions to increase patient flexibility. I wonder where you heard that before. It may be necessary to spend dedicated treatment time to manually stretch the heel or the hamstrings and the heel cords more aggressively because of the amount of tone and tightening that can occur and the limitations that they can provide to function. And again, use of static splinting, PRN. Improving awareness is also another goal of inpatient rehab. We want to increase awareness of the self and the environment, not only for physical function, but also behavioral and cognitive function. This is most often accomplished through the administration of various sensory stimuli. And we want to be sure to educate the family on ways to orient the patient and increase self and environmental awareness. We want the family members to be cautioned against overstimulation because remember, this can cause our patients to become agitated and fatigued. And we want to vary the amounts and intensities of the stimuli provided because that's real life. Functional mobility training should always be an essential part of an inpatient rehab patient's plan of care. And so we're going to implement functional mobility training in this patient population, but depending on their level of function, it may be necessary to co-treat early on and get occupational therapy involved, not only so that you have more hands to assist the patient and provide safety and get what you need out of the patient, but also to facilitate the maximum independence that they need for discharge. Prolonged stretch, weight-bearing, approximation, slow rhythmic rotation, and tendon pressure help to inhibit tone. So those are all the things that we've talked about in previous lectures is for how to reduce abnormal muscle tone to facilitate normal motor function. So remember, using all of those things can help to achieve that. Total body postures and positions such as upper and lower trunk rotation, sitting, prone, and standing are also effective in decreasing abnormal tone, so getting them out of a supine position. Once the abnormal muscle tone has been decreased, normal movement patterns and task-specific training must be encouraged to promote motor relearning. We want early emphasis on development of postural control, so ensuring that we have appropriate trunk and head control in sitting before we move to standing, and then progressively increasing the dynamic challenge in standing. Again, using the developmental postures, taking them through that prone sequence of prone, prone on elbows, prone propping, quadruped, tall kneeling, half kneeling, standing. Selection of common daily activities often result in active movement attempts by the patient because they are meaningful and have been performed thousands of times. And so if we want to get volitional muscle control, we want to practice things that the patient is most familiar with. Hand over hand provides proprioceptive and kinesthetic feedback, so this is where you complete the activity with your hand over the patient's hand to help guide them and understand how much force they need, how much movement they need, what coordination they need, all of those factors. Activities that incorporate visual tracking or maintain visual contact with an object assist in the development of head control, and so using mirrors can become really important with this patient population. Sitting activities will work to increase arousal, and so already we're achieving one of our goals for our patient. They also provide a challenge to the patient's postural alignment and righting and equilibrium responses. And remember, we need to retrain those depending on the level of damage to the brain. Patients who exhibit a strong extensor tone may become flexed and hypotonic once they are upright, and so we're still not getting normal muscle activation the way that we need to, but we're seeing a breaking up of that abnormal tone to where we can try to start facilitating motor function. Weight bearing on the upper extremities decreases abnormal muscle tone and also promotes proximal joint stability, so again, taking them through that prone progression will help to achieve that. For transfers, a sit pivot is recommended for patients who have low function and lack trunk control. Beyond that, we want to start progressing them to whatever their normal level of function transfer will need to be. When we move into standing, we may initially need to use a tilt table or standing frame. This can be as a result of abnormal muscle tone, poor trunk control, or even orthostatic changes, and so being able to progressively take them to that upright position without requiring much volitional control is a useful tactic with the tilt table and standing frame. Activities that increase awareness and cognition can be performed in standing, and again, that upright position helps to increase arousal. And body weight support gait training can be initiated in standing because, again, we have the patient more supported to facilitate the proper movements. When we are planning our treatment, we need to remember that extrinsic feedback is important early on, and so that means feedback from outside of the person. So whether that's the use of biofeedback or therapist cues, something outside of the person that lets them get the feedback that they need to learn the correct way to do things before they can become reliant on intrinsic feedback. We also want to consider to plan for the patient's best times of day, especially if they are a patient who experiences extreme fatigue or extreme agitation. We don't want to try to treat a patient during those periods of time, especially if they have better times of day, or we can get more effective treatment sessions out of them. Limit your frustration and your patient's frustration by gearing the interventions towards the patient's preferences and needs. TBI patients can be a lot like treating a pediatric population where you have to kind of go with the flow, and while you may have had a plan, you have to be flexible in that. And the more you can gear your interventions towards what the patient needs to be able to do, the more compliance you're likely going to get, the better behavior you're going to get, and the better outcomes you're going to achieve. And repetition and practice are needed. So even if they say they don't want to do it again, find a different way to present the same skill so that way we can enhance their functional independence. When considering the physical environment, we want to utilize low stim environments, and remember that structure is very important. So not the structure of the environment specifically, but providing structure to their environment, making sure that things aren't going to enter their environment and disrupt what you're trying to achieve without you having control over that. And this is not to say that treatment for patients following TBI ends at inpatient rehab, but the bulk of what we are going to do as therapists would be to try to restore function for discharge from inpatient rehab. And then outpatient rehab, we would conceivably have a deconditioned patient that we're trying to restore function with, and so we have less considerations of the TBI. Our goal in inpatient is to kind of limit the effects of the TBI, so that way when they are discharged from inpatient rehab, they have their maximal functional independence, and then outpatient rehab is as needed to maintain or promote higher levels as needed. I do not think that this video will play. I will give it a shot, but if it doesn't, this is a story about a patient following a traumatic brain injury. I believe, if I remember correctly, her story was about a tumor being removed from her brain, secondary to cancer. And so this was not a trauma-related traumatic brain injury, but still shows a great story of a patient progressing through their rehab process. Yeah, it's not going to play, so just go check out the slide online or on your own and play this video independently.